Welcome to the first part of our two-part special episode, Practice Saver to Practice Builder, Telehealth in Eye Care. We're glad you've joined us for this discussion entitled Finding Synergies. Doctors Ranya Habash and Damon Dierker will speak with colleagues Doctors Brianna Rhue and Blake Williamson about clinical and practice barriers with telehealth, co-management best practices, and common telehealth misconceptions. This podcast is supported with advertising by Novartis Pharmaceuticals Corporation. The opinions and views expressed during this program are those of the individual participants and are not necessarily those of Novartis Pharmaceuticals Corporation or its affiliates.
Good evening, everyone. Welcome to part 2 of our webinar event, Practice Saver to Practice Builder, Telehealth in Eye Care, Finding Synergies. We'd like to thank Novartis for supporting this program. And to our audience, please feel free to submit questions throughout the program via the Q&A field at the bottom of your screen. We'll address them at the end of the program. This should be a really lively discussion. And we have 3 really amazing co-panelists with me. So Damon Dierker, you're going to be a co-moderator. And of course, we have the great Brianna Rhue and Blake Williamson joining us as well. So we should have a really good sort of, fireside chat, and we'll talk about a lot of interesting things. And also, really interestingly, what sets this program apart from others is that we're going to talk about the ophthalmology-optometry relationship in terms of telehealth and how we can make use of, working together. So with that, let's get started. One of the things I wanted to talk about first probably is, let's talk a little bit about the optometry-ophthalmology relationship. Let's just start right there. Are you guys co-managing via telehealth? Brianna, do you want to start us off?
Sure. I'm excited to be here this evening. So thank you, Novartis, for having us in PMC. I think we can really use this for co-management in specific ways when it comes to cataract referrals, when it comes to LASIK referrals, where we can do all of the pre-data screening with all of the testing that we can do, and then refer them to you guys to have this telemedicine conference before the patient goes in. And I think it takes the patient away from having that bedside manner or being scared in the chair, to really release them so they can have a better conversation of what's best for the patient, especially when it comes to things like LensX or laser assisted cataract surgery and updating lens implants. So you can have both family members there, because I know we're limiting family members into the chair. And so we know patients only remember 30% of what you say. And then when we go into these higher forms of cataract surgery, especially, you're going to derail yourself, because now they're going to go home and have to talk to their beloved one who's now saying, you went in for a procedure that was going to be covered, and now you're telling me it's a $6,000 bill. So where did we go wrong in this conversation? So I think we really can get good at the data collection and then using telemedicine in that manner for co-management. So that's how we've been using it.
I think that is such a great segue to this entire discussion, because probably one of our best visits, and Blake, you can probably agree with me on this, is the refractive counseling and multifocal IOL talks that we have with patients from home. And that's been really great, because exactly like what you said, they're sitting at home and they've got their family members with them. They feel more comfortable. Someone says, or a lot of patients actually say that it's more personal than an in-person visit a lot of times. So what you're saying makes perfect sense to me. Blake and Damon, you guys want to comment on that?
Yeah, I think Sumitra Kandawal was one of the first doctors I heard actually say, you know what, this is actually more personal because I'm unmasked, and I hadn't really thought about that until she mentioned it. So I do think there's something to that. For us, all the counseling, for LASIK at least, and our other vision correction procedures that we do at Williamson Eye is all done virtually now. And as a result of that, our adoption rates for patients seeking vision correction procedures has way outdone 2019 and 2018 numbers as well. So I think that that's been a huge piece. I think that, patients, enjoy the fact that on their own time, when they're comfortable, from their house or sometimes from their vehicle, pulled over on the side of the road, of course, they get to have a chat with our counselors about what different technologies exist to help them see better. On the co-management piece, it's not something that I do yet, but it's certainly something I'm interested in. Right now, I have 7 different locations of Williamson I, but we're looking at expanding even more. But some of these outerlining areas are quite far, and so sometimes we'd be asking patients to drive almost an hour, to come in for a simple conversation that we could have over a Zoom meeting like this. So it's something that my team and I are looking at very closely and anxious to hear for those people who are doing it successfully.
Yeah, we're not quite co-managing yet. I think we are definitely using this in the perioperative period very effectively, both with telephone calls and video visits. When we had the shutdown months ago and we weren't seeing them at all in the office, our surgeons did video visits to kind of reacclimate themselves with the patient and get them ready for surgery. Now some of that is more telephone with our counselors. But I really see the opportunity here in these referral center settings and co-management relationships to have a patient in a chair, 30, 60 minutes away from an office like Blake has or like I have, and we have a conversation with the patient and their optometrist, and have a good conversation with the doctor who knows them best to be able to understand what's going on, what their goals are. So I think we're still scratching the surface on that. I think there's a lot of opportunity. It's just going to come down to logistics, and in some cases, how are people being compensated for this as well, and those things are evolving. So I think that's exciting. I don't think we're just scratching the surface though.
Well, so that's a perfect segue to what I wanted to actually launch into next, was the reimbursement part. So, first of all, just to recap, this one segment, we're talking about doing preoperative counseling visits via telehealth and having optometry do the measurements first, and then setting everything up, and then we do the counseling part. But you guys touched on some really important things. Number one, the patient is more relaxed. Number two, they've got their family members with them, so they're actually comprehending the material a lot better, and they get to weigh in on it a lot more. Number three, we're developing a better relationship with them because they're essentially inviting us into their homes now rather than them coming into our offices. Number four, higher conversion rates. That is uncontested. Every single doctor you talk to will say the same thing: higher conversion rates when we do it this way. And it's for all the reasons that we mentioned before. Now comes the last part. How do we tie that back into the optometry-ophthalmology relationship? And Damon, you hit it perfectly. I mean, there are codes for doctor-to-doctor consults, and they can be used between ophthalmology and optometry. So if you're in the same tax ID and you're using between ophthalmologists, for instance, it wouldn't work on the same date of service. But between optometry and ophthalmology, or between two different practices that have different tax ID numbers, you can use that. So the way it would work is this way. Let's say I wanted you to do, a multifocal contact lens fitting on a patient who I was thinking might be a good PanOptix candidate. Okay. And I sent the patient to you or Brianna, and I said, well, you guys let them try out multifocals first, or monovision, or whatever, right? To give us a little bit more information about whether or not they can tolerate that. Well, guess what? I'm the referring physician in that situation, and I would write a little note that says, discuss with patient agrees, for me to discuss with Dr. Dierker or Dr. Rhue, gave consent. And then that's a billable service because I reached out to you for some information. Now, you as the consulting physician would then send me a report back after you saw the patient, and that's a billable based on time type of visit. So that code would be, based on how much time you spent preparing the report to me and talking, letting me know the information. So it's actually a really good system because we were already doing all that, right? But
we just weren't getting paid.
We were already doing it, but that's the logistics way to do it. You just make a little encounter that says, hey, reach out to Dr. Dierker, patient accepted, or patient said okay. And, then you bill, if you're the referring physician, the 99452 code. And then on the other end, if you're the consultant, you bill based on time, and it's the 9944 codes. So 99446, 7, or 8, or 9. And they pay, a pretty decent amount. So again, the thing to remember here is we were already doing this stuff for free. So, it's not, a huge addition to your practice, but, over time it builds up. And, in this day and age, we really need to take advantage of these types of codes that are coming up.
So I'm interested in how people are going to implement that on a wider level logistically, because we're all really busy. We're all having to deal with enhanced sanitation and PPE. Is how are we going to set up a consult where it's going to make sense for an optometrist to consult with maybe another optometrist or an ophthalmologist? How do we make that happen? What are you doing, Ranya, right now in your practice to facilitate that?
Yeah, I'm glad you asked that, actually. So there are two ways to go about this. Number one, if the patient is with you in the room, okay, that is one type of situation. So you could, I could send you a text and say, hey, are you free to talk for a second? And then we could get you on the call, on a Zoom call, and all talk together. The second scenario, though, which is probably the more common one when we're talking about doctor-to-doctor consults, is, patients in my office, and I say, you know what? I think the best thing for you is if you go see Dr. Dierker and he does a multifocal contact lens fitting so you can try it out first, or let's try monovision before we do it surgically. And so I'm going to discuss it with him. Is that okay with you? Patient says, yes, that's awesome. Thank you. And then we send them to you. You do your fitting. You send me a report. And then you bill the E&M service plus the consultant code back to me.
Got it. With patient consent.
Yeah, I have to document that I asked the patient. You should always document patient consent, but I always let the patient know, and they really appreciate this. I mean, this is a huge service for them to get a second opinion or another set of eyes looking at their situation.
Blake, do you see that working in your network?
Yeah, the way I see this working for us would be, number one, I think that I would have to have a dedicated time for that. And I know that we all have said that if you're going to be doing telemedicine, it can't be on the fly. It needs to be, hey, this hour is my, of the day, whether it's the last hour of the day, is dedicated to telemedicine. So I can kind of foresee a situation where, like, literally maybe the last, 30 minutes or last hour of my day, maybe 30 minutes of my day is specifically devoted to cataract consultations from referring optometrists, right? And so, and from the OD level, sometimes, you call the ophthalmologist to get them in for consult, and they can't get them in for weeks, right? 2, 3, 4 weeks sometimes. So what if you said, hey, actually, if you can come back later today at the end of the day, you can actually meet with your surgeon today virtually. Like, I feel like that would be a good way to kind of actually grow my co-management network by being able to provide like same day consults, right? So I think that would be a very interesting way to do it. And literally the last 30 minutes, I'd just hop on and we would have a conversation just like this. And then I can see them same day. Obviously, I want to take a look at the eye with a slit lamp, right? So I would do that on the day of surgery, first thing, which I do already for some of our patients who travel from out of town. So that's how I think it might work for us.
So I think that's good. I just want to weigh in really quick here. So what I was talking about is actually an asynchronous type of visit. And that means the patient does not need to be there. So this is just us talking about a patient's case after hours, on the drive home, whatever. And the patient doesn't need to be there. So you don't need to allot specific time or anything. Does that make sense? So there's two ways of doing that. You can either do a formal one, like you're saying, Blake, which is an awesome idea. And then there's the informal ones, which happen 10,000 times a day anyway between us, where we just like curbside a buddy and ask or talk about a case. So those two are different options.
What are you guys doing like that on one of our conversations where that 1 day post-op has not become that important? I mean, it still is important, but not as important as it once was, especially when we were during lockdown. I think it's important as the OD, MD referrals get really, really synergistic here, is to really use your referring physicians to do those visits, because I think it's important as we move forward. We're going to all get busier and busier as things are going on. And we need our ophthalmologists to be available for those surgeries. And you can use optometry in those ways better, actually, than I think what we're utilizing now for those 1 day post-ops. How's it going? Are you guys now seeing your 1 day post-op still, or are you kind of doing those virtually?
So our optometrists here at Bascom have been great. They're doing 0-day post-ops for the patients just to keep them from having to come back a second time. That has been a huge hit. And then we look at their notes, and I still call the patients at night, but at least then I have a pressure check, a vision, all the basic stuff done. That's been incredible for us. But I want to just let Blake kind of take this one. Blake has arguably the most famous video online about post-op day 0 visits or post-op day 1 visits via telehealth. So please take it away, Blake.
My situation is, we do a high volume of surgery. So often I'm doing between 30 and 40 cataract surgeries in a morning. And so before COVID, that means that I'd have 30 or 40, patients in the waiting room, and that we would have to kind of churn through. And that was taking up slots for, patients who could be coming in for consults, right? So I said, there's got to be a better way to do this. And so that's what we did, the 1-day post-op virtually. And I thought about it. I consulted with a bunch of different colleagues, and I was like, what are you really looking for in that 1-day FAAO, post-op? The biggest thing is the IOP spike. So I started checking pressure with a bare keratinometer before they left, right? We also give them a Diamox on the table and a Diamox for that evening as well. So I felt like I'm doing okay from an IOP perspective. Of course, any patient who is getting a MIGS procedure or a patient with glaucoma, I do see them personally on day 1. But I'm just talking about cataract surgery only, no combination procedures. So IOP you're not worried about. And then you're like, okay, well, what about TAS? I mean, gosh, that's so incredibly rare. But if they did have TAS, that should be something that you would see virtually whenever you see the eye. They'd say, I can't see well. My eye is red. My cornea is cloudy. You can actually make it out. So I'm not worried about TAS, I guess you could be worried about maybe iris going to the wound or something like that, but then you'd see they wouldn't have a round pupil. But when I'm looking at these patients, if they have a round pupil, a clear cornea, the eye's white and quiet, they're happy, within seconds, I've completed that post-op exam. So I can do 30 plus post-op day 1 visits in a matter of like 30 minutes, literally. So it's been a tremendous, tremendous boost to our team in terms of efficiency. I come in 30 minutes early, I knock those out, and then I begin my day. And I also like that connection because often I don't get to see those patients on the day of surgery because we're moving so fast. So they say, Doc, I didn't even get a chance to see you. Like Ranya, I do personally phone them that evening just for that personal touch. But I find the post-op day 1 adds another layer of that personal touch to our system. So it's been great for us.
So do you have 4 or 5 computers lined up and you just go up and down, or how are you doing that logistically?
I have 2 iPads, and I have both of my gals that I work with closely on my team standing there, and they literally are hitting, they're getting the patient on the screen, and then they're handing them to me real time, one after the other, so that there's no seconds wasted in between. So literally, we've got it down to it's like fake, it's like cataract. We've got it down to like a efficiency science thing. But it's been great.
We can see like a minute of it if you want, because it is really a sight to see. It's really worth it if you haven't seen it yet.
Just think about the total number of hours that you're saving for you, your staff, your patient, the patient's family that has to drive them in. I mean, literally, it's
hours,
hundreds of hours potentially, right? Depending on where the patients are coming from and how it affects their lives. So, I mean, if we can do this in a way that is still safe for the patient, which I certainly think it is, I think that's really exciting.
Anything that you're worried about, you'll see. A cornea abrasion, they're going to tell you this hurts. TAS, they're not going to be able to see. The eye's going to be red. All those things. I just asked myself, why do we have to see them on day 1? I started thinking, and as long as you have that video and you get a good image, I think I feel safe doing it. Yeah, here's the video here. Ranya has it.
Hey, it's Dr. Williamson here at Williamson Eye Center.
I'm going to fast forward just a tiny bit.
I did it like real time.
All right. I love how you put on your coat here and make it all official. There's 30 patients on the screen.
Let's come on in.
Oh, you're just like admitting them and then kicking them out of the waiting room.
We're in the virtual waiting room here. You can see all these patients.
Ah, got it. Virtual waiting room. So they're all waiting for you. You're just bringing them in. I see it now. That makes sense.
We're going to go to the very first one. Can you hear me?
Yes, I can.
Okay. How you doing? Everything okay?
Yeah, I'm doing good. How are you today?
I'm doing fine. Thanks for allowing me to share this with my colleagues to show them how to do telemedicine. Eyes doing okay? No eye pain or anything?
I'm sorry?
No eye pain or anything?
Oh, no.
Okay.
No pain at all.
Let me take a look at that eye that I did yesterday. Bring it real close to the camera, please. Good. I want you to look up and to the left. Right? Perfect. Fantastic. So everything looks good. So the cornea is nice and clear. The pupil is round. Everything looks excellent. You're doing very, very well. So I want you to continue to take all of your post-operative drops. And as long as you're doing well, we'll see you in clinic next week. They'll give you a call and let you know exactly when that's going to be. If you happen to have any redness or loss of vision or eye pain or anything over the next 3 or 4 days, I do want you to come on in right away. But I don't expect that. I expect to see you at your normal scheduled appointment next week, okay? All right. Hey, how are you?
Wow.
I'm gonna stop sharing
Nice.
there. But how phenomenal is that? Like, we could explain it all day long, but then until you actually see Blake doing that, you can't really get it. I got to commend you on that. That's really amazing.
Thanks, Ranya. I appreciate it.
Yeah, so that's great to see. And I think it helps us to transition to part 2 of the program, which is barriers. Because I could be the naysayer and say, Blake, you're not checking there for cells. You can't see a little tiny piece of cortex there. Maybe there's a subtle wound leak that's going to be a problem in a day or two. Unlikely, but maybe there's something weird. You shouldn't be doing that. So I think there's a lot of issues that we could propose as being a problem that really we find solutions for. Or maybe it really isn't a big problem. Maybe we just need to rethink, why are we doing that visit? But I have colleagues that, I'm not going to do telemedicine because I can't look at the cornea close enough, or I can't do this or that. So I think that we really need to focus on what we can do. We know there's some things that we can't do, and those are only going to get better as the technology gets better, as we get more acclimated to it, as we start doing these visits at home that are really remote monitoring patients with retina issues, glaucoma issues. I think all of the technology to allow us to do the things that we think we need to do is going to be there eventually. I think there's so much we can do now that we don't even think about. Post-op visits, contact lens evaluations, dry eye follow-ups, triaging, there's so much we can do. But the barriers, I think, are mostly self-inflicted wounds, right? It's changing your protocol, changing what you think is the right way to do things. Oh, yeah, I have to do it like this, or my staff will never do this, or my patients will never accept that. It's the change, the resistance on the provider end that I think is the biggest barrier in my mind. And I'm interested in what everyone thinks about that and what they're seeing in their practices and in their community.
Well, I'll add to that part. I think that as technology is advancing, especially in health technology, so Ranya and I, we've talked a little bit about it because I have my own app. I think that we have to be the ones to take this and be the ones to innovate and to be the ones to do it. Or there's going to be companies behind us that are going to come in and not do it right. So we have to be the leaders and the forefront thinkers here to really move this forward, or we're going to be legislating against things that are really harmful for patients. So we know what's right and we know what we can do, and we have to be the leaders to make that happen. And unfortunately, doctors, we do kind of get stuck in our ways a little bit, and we have to be the ones to stay in it with technology. It's here to stay. It's not going away. Things are going to get better, like you said, Damon, but we can't put ourselves on the back burner here and let technology advance faster than us. And I think all of us that really in March took this by the horns and said, okay, it's here. How do I get on telemedicine? I think I would set my own telemedicine thing up in 2 minutes or less, had my first telemedicine visit when we shut down. We really just kind of got thrown to the wolves to do it. And so we all learned very, very quickly. It is possible in a lot of cases. Yeah, there's always going to be barriers, but we figured those out really, really fast. But I think it's important that we understand that we have to be the ones that are developing this technology, because we can't let others come in and cut us out. So I think that's where people hold themselves back.
Yeah, I think that a great sort of analogy was the experience with transitioning to EMR. It's similar. It's a foreign thing. It's a new thing that you had to kind of get used to. And like EMR, our experience with transitioning to EMR many years ago, it was sort of the older physicians in the practice that were a bit more hesitant and it's been similar with telemedicine as well. I think that if I were to offer, some feedback on what's that?
I'm gonna let you finish your thought, but I will counter that, what you just said about older physicians not being able to adapt as fast.
Oh, I'm just talking about my practice. I have no doubt that that's not everywhere, but in our practice, that's been the way it is. But my feedback would be, to counterbalance that, would be to you have to have a champion of it in your practice. No technology is going to take off, whether it's femtosecond lasers or trifocals or MIGs or dry eye. None of that's going to happen unless you have somebody who's a real believer and can actually prove it, right? So I think having someone listening to this saying, gosh, I don't know how I can get this started in my practice, you need to designate someone, hopefully yourself, if you're watching this, to be the leader of this charge. And number two, if you're not in control of your practice in terms of from an ownership perspective, and you're concerned about the partners allowing this, they love the word pilot. Piloting anything is great. You can say, hey, you know what? You may have some reservations, but let me pilot this just for a little bit. And I think that you can kind of show them and prove how successful you can be.
Yeah, Brianna and I know, though, it's called death by pilot, because nothing ever happens. It just okay. So going back to what I meant before about older physicians not being as easily adaptable. So the reason I said that is because I think the older physicians have taken to telehealth a lot better than the younger ones. And here's why. And I want you guys to tell me what you think. This has just been my observation. So how many times have you all walked in and seen a resident sitting there at the computer typing away, the room lights are off, and they've missed something like, I don't know, Bell's palsy or cellulitis or something like that, because they have been so zoomed in on the corneal endothelial areas that they've forgotten to look at the patient. And this is where we get old school medicine. Okay, this is where we're going back to old school medicine. Telehealth requires you to sit there and look at the patient and assess the patient as a whole, and to let go of that thinking that you need every single element of the exam met, because you don't with telemedicine, right? We're not talking about billing based on, every nuance of the exam or every part of the eye. We're talking about a global type of visit, which is more, time-based billing or medical decision management. But, going back to that point, this is about sitting back and looking at the patient as a whole and doing more old school medicine. And because of that, I'm telling you, I've sseen that the older physicians seem to get it a lot better because they're used to doing this type of old school medicine. What do you guys think about that?
Yeah, I was interesting when we were during the lockdown in Indiana. Was about 8-9 weeks where we were just doing emergent care only. Our senior partner, prolific cataract surgeon, we did a telehealth Zoom meeting to kind of talk about how we were going to implement this. And his final words was, telemedicine is the future of eye care, and it always will be. So he was somewhat pessimistic as to whether or not this is actually going to happen. He was the first person in our practice to do virtual visits for all of his cataract consults when we're getting ready for surgery. So he took it on and had great conversations and said, wow, I never had any idea this was so good. So he actually took the lead on it when he was the most pessimistic to start with.
Blake, what do you think about that? I mean, I know you have a great practice and you are used to kind of sitting back and having that relationship with the patient, but I just feel kids these days, the residents that I see, I'm telling you, like, they are just so focused because they have so much to do and to, so many boxes to click that they forget to actually look at the patient. And I really do think that's, where telemedicine diagnosis is much more important. Which is also another good segue into what we wanted to talk about, Damon, right? About what kinds of things can you and can you not do with telehealth? And so let's do some rapid fire questioning. So let's pretend that you have a patient sitting in front of you and, it's just a virtual visit. You have no technology, you have nothing to examine them with, but, they start telling you they have flashing lights and floaters since last night, okay? So you ask them, do you have eye pain? No, I don't have any eye pain, but here are my glasses and they're this thick, right? Or, oh, I got a bump on my head. That's telemedicine. And you're gonna bring them in and you're gonna look at that retina. So for the people who say there's no way you can assess flashes and floaters or retinal problems via telehealth, that's your answer. I mean, you are triaging that patient based on what they're saying because you're listening to them.
Yeah, and depending on how your practice works, I know we've all seen patients that come in with flashes and floaters. Well, they're having a migraine, and it took me 30 seconds of discussion with the patient to figure that out. And maybe they got on the phone with someone in my staff that's not as, well trained at triaging those patients. And the patient drove in, they're nervous wreck. The flashes are starting to wear off a little bit. They're starting to get a little bit of a headache. And I said, yeah, you have a migraine. And we could have, saved them a lot of time, saved my staff a lot of time just by having that conversation. We determined, boy, they've got floaters, they've got, flashes in their periphery. Yeah, you need to come in. And you know what? I already have the chief complaint. I already have the HBI. We've already started the encounter. Right. So when you come here, we're going to put some drops in. We're going to I'll be looking at your retina within 20 minutes of the time that you arrive in my office. They're going to have a better experience. And if I need to get them to a retina specialist, I'm expediting their care.
Amen. That was very well said. Brianna, you look like you want to jump on that too. Go for it.
Well, yeah, and it's the same thing. So if I, Friday at 4 o'clock and that kind of comes in, why am I going to waste a visit for that patient if I know that it's got to be, triaged out? And same thing as Damon said. So I think that's what we were triaging a lot with foreign bodies and those types of things. So yeah, do I need to see you, or this can wait a little bit? So, we all have our phones full of people that have text us their pictures and what's wrong. And I think what we have to do is utilize our services and get paid for it. I think that's what this comes down to. And I think, Ranya, when you're stating the younger to the older generation, where we have a lot to protect, right? And I think that's where this gets a little nerve-wracking is, are we going to be around in 10 or 15 or 20 years? So I think that's the apprehension a little bit. So if we can show people how to take care of their patients, how to get paid for it, like attorneys do for their time, right? That's essentially what we're doing here. Then we can get a lot more people on board. And I think that's where a lot of the apprehension comes from. So we have to get better at billing and coding. We have to get better at charging for our time and then collecting for it. So there's got to be some boundaries set between the doctor-patient relationship, which I think we've blurred those lines a lot, and we have to get them back.
Excellent. You guys are so good. That was excellent. Blake, do you have any thoughts?
Yeah, I mean, I think the triage thing is something that we don't do enough of. I feel like at our practice specifically, there's that Friday, at 4:30, our front desk gets a call, hey, I got something wrong with my eye. Can I please come in? And we don't know. That's all I hear. And they say, well, you got, even though I'm done with seeing my patients and I was about to go home, I'm sitting there waiting for 20, 30 minutes for the patient to come. They show up and it's the subcon team, so it's kind of like that type of stuff is difficult. And even if it's not at the end of the day on a Friday, let's just say it's in the middle of a busy clinic schedule. Oftentimes when you work that patient in for their emergency visit, that can bump someone who was there for a cataract consult or a LASIK consult, and now they're spending more time in the waiting room. And I just wish that there was some way for our practice to look at doing, having a on-call person for triage telemedicine each day. You do the triage for the whole practice that one day and rotate it. I think that would be a really cool thing to do.
So we're doing that at Bascom too. We started that service. It's kind of like an urgent care virtual clinic. And it started during the pandemic, but it's still going. And it's because, our wait times in the ER are like 4 hours. And so, and to see one of us takes months. And so now when patients call in and they have an acute issue, they say, I'm losing vision, or I have a red eye, or my eye hurts, or whatever. We send them into a queue where actually it's our optometrists who are manning this, and they're doing a really great job with it. So they're doing the telemedicine visit. We're capturing the revenue and they're getting that revenue. And 70% of the time, they saved the patient from having to come in. They were able to deal with those issues 70% of the time. The other 30%, exactly like you said, Damon, those patients were expedited because we found that it wasn't, it was really new flashes and floaters, and they did need to come in and they were expedited to a retina specialist instead. So that whole triage tree that we've been using has been incredibly successful. It's been saving patients from having to come in and wait. And then when they do call for an appointment, they're not getting that, oh, your next available is 6 months. Now it's, you can have an appointment today. and we're getting them dealt with really quickly and capturing all that revenue so they're not going to urgent care or other physicians or whatever.
Thank you for tuning in to part 1 of our 2-part special episode, Practice Saver to Practice Builder, Telehealth in Eye Care, Finding Synergies. Please stay tuned for part 2 of this series, where Doctors Ranya Habash, Damon Dierker, Brianna Rhue, and Blake Williamson conclude their conversation by debunking some common telehealth misconceptions and addressable barriers, as well as hosting a question and answer session. This podcast was supported with advertising by Novartis Pharmaceuticals Corporation. The opinions and views expressed during this program are those of the individual participants and are not necessarily those of Novartis Pharmaceuticals Corporation or its affiliates.